Good.
Ready when you are, and it's just a back and forth.
Okay.
So make sure that works for you.
All right. So my name is Tina Mix. I'm a second-year pediatric resident at the University for New Mexico, and my presentation today is going to be discussing the human papillomavirus vaccination. So some thoughts to consider when thinking about HPV. What is it actually? What does it cause? Just some basic information about the vaccine. There have been some updates to it in the recent years. And why is the vaccine important in New Mexico in particular? So HPV is a small DNA virus that we know. It can cause infections that range from benign infections that resolve on their own to more malignant infections that can cause cancer later on down the road. So some of the high-risk genotypes are listed there. You can see all the numbers. And if you look at that, you notice that the malignant ones are listed. So cervical cancer is the most common HPV-associated cancer in women, primarily caused by the genotype 16 and 18. In fact, 16 is found in approximately 50% of cervical cancers. The next one is head and neck cancers. So this is oropharyngeal squamous cell cancers. If they have these genotypes, they have a 2 to 4-fold increase in their cancer risk to develop this squamous cell cancer. For the anal cancer, 16 again is the most common cause of this genotype. However, they are doing some studies that note different genotypes can become malignant with a co-infection with HIV. So something to look out for in the future. Penile cancer is another one. 70% of penile cancers are caused by HPV 16 again. And if someone has a history of genital warts, that increases their cancer risk by 5.9% in the future. And all this information is from CDC and up to date as well, so you can find all of that very easily. So the vaccine itself was recommended in the United States starting in 2006. There are current guidelines for giving the vaccine. It's a 3-vaccine series. You get the first one, and then the second one you get 1 to 2 months after that, followed by a third vaccine 6 months after that. Something that's important to know is that once you start the vaccination series, even if the patient doesn't come back for the 1 to 2 month second vaccine and they come back 6 months later or a year later, you can still give the second and third vaccines in that regular schedule and not be concerned that they're not being covered. The starting age that is currently recommended is 11 to 12-year-old, females and males now. And in females, you can give it up to 26 years of age, and in males, up to 21 years of age. There are some others, like very specific recommendations in men that have sex with other men. You can give it up to a later age. I think it's the 26-year-old, just like females. There are now 3 vaccines. I'm not entirely sure of when, what are most commonly being used. The Gardasil 9 is the newest one. The Cervarix is the one that was initially out on the market. The Cervarix covers the HPV genotype 16 and 18, whereas Gardasil is a quadrivalent and it covers 6, 11, 16, and 18. Gardasil 9 covers 9 of them, so in addition to the quadrivalent, it covers 31, 33, 45, 52, and 58. And so that's covering a lot more of those genotypes that are being shown to have specific co-infection deals with HIV. So that's important to think about. So the importance of vaccinating, this article that was listed shows that over a quality adjusted life year, which is discussing a year in which you're in perfect health, you actually have a decrease cost when the vaccine has been given. And so essentially what this all boils down to is that the vaccine outweighs the cost of caring for patients that end up with these HPV-associated cancers. So if they have cervical cancer, there's an increase in their cost. If you have any reduction in their quality of life because they have an HPV-related outcome, so like warts and treatment and all of that, you can see that there's a cost listed there. And it's important to realize that this is a big deal because alone in the US between 2004 and 2008, there were over 33,000 HPV-associated cancers per year during that time period. And of those, 21,000 were female and about 12,000 were male. So this is affecting a large span of the population in the United States. This slide essentially discussed the importance of cervical cancer, and it's showing the incidence rates by race and ethnicity. This is the newest data out there, and you can see that Hispanic women are at the highest risk, followed by African Americans. And something that I thought was interesting is that Native Americans were pretty low on that list. So in New Mexico, our population is largely Hispanic. I believe it's 48% over the last census period. You can also see what's interesting is that the rate of cervical cancer is going down. And so you can see in about 2006, whenever this vaccine got brought out into the public, you can see that it's gone steadily down from that time period. So that's good news for us. So this is the slide talking about New Mexico specifically and Bernalillo County. So this data comes from 1995 to 2004, so it's a little bit older data, but still important. And this comes from the New Mexico HPV PAP registry. So you can see that cervical cancer incidence, those are actual numbers over that time period of new cases. And then cervical cancer deaths, you can see on the right-hand side there. And then just below that, I did the population estimates by race and ethnicity to highlight the importance of the graph previous, that in New Mexico, we have a 40.2% Hispanic population, and in Bernalillo County alone, it's about the same as New Mexico. And then our American Indian population is also relatively high within the United States. So this slide shows the HPV and when you notice that there's a rise in positive tests for HPV. So you can see that among early 20s, late teens, there's a spike in HPV infections. So the black line shows just any HPV regardless of the benign versus the more malignant forms. And then the red line shows the high risk HPV infections, and the green line shows 16 or 18. And then the blue line at the very bottom, of course, shows the low risk genotypes by age. And you can see that we need to target a population with this vaccine prior to them getting to that spike in HPV infections. This information from the New Mexico Youth Risk and Resiliency Survey that was put out in 2013 shows, it breaks everything down into risk behaviors. One such breakdown is sexual activity in grades 6 through 8. So first time having sex in New Mexico, total of all of those grades is 8.3%. And in Bernalillo County alone, 8.6%. So we're a little bit higher here in this county than statewide. And then on the right-hand side, you can see that sexual activity in Bernalillo County broken down by the grades that they're in. And that's important because you can think that in 6th grade, most kids are probably 11 to 12, 7th grade, 12 to 13, and so on. So you can see in 6th grade that 1.5% of those children are reporting having sex, and it continues to go up from that point. And this is very important for the timing of the vaccine because we want them to be protected against HPV before they start having sex so that they are protected against the virus itself as well as the sequelae from that viral infection. And these numbers, interestingly enough, have actually gone down from the numbers reported in the 2009 survey. So another group to look at that I thought was important is the high school group, so grades 9 to 12, and you can see that a good percentage of them having ever been sexually active is high. So in New Mexico, 39.9, in Bernalillo County, 40%. And then currently sexually active, a lower number, but still pretty high, 26.8% and 26.7% in Bernalillo County. So again, it just kind of fortifies that we need to give this vaccine prior to this time period, because by this time, while it's still entirely worthwhile to give the vaccine, we may be missing a window in which we can be fighting these kind of infections. So I have a case to discuss. I'll just read it out. So Melissa is a healthy 11-year-old female. She presents to your clinic with her mom. As part of the visit of her well child check, a discussion is initiated regarding the necessary vaccines for her age. You mentioned that she's going to need the meningococcal, HPV, and Tdap vaccines. Her mom seems to be fine with the other vaccines, but is concerned about her daughter receiving the HPV vaccine. And so how would you handle this mother's concerns in your clinical setting? So in this case, there are several right answers that are possible. Everyone has their own way of approaching parents that have concerns. I think the first thing to do, obviously, is to address what her concern specifically is, and then you're going to have a better stance as to how to educate and give more information. The CDC actually has a wonderful one-page paper that talks about how to talk to parents about the HPV vaccine. The first tip that it has at the very top of the sheet in bold letters is that we need to just discuss HPV as if it were just like any other vaccine. So whenever we say Tdap, we don't, have some kind of stigma attached to it. We just say Tdap. If we talk about meningococcal, we talk about it causing an infection in the brain and meningitis, and we just don't have the same stigma, I think. And we're definitely getting better with discussing this vaccine. And they said, so just discuss it like a regular vaccine, and then also just use it and say that it protects against HPV cancers. Usually if people hear the word cancer, they're going to think a little bit more closely about it rather than it helps prevent against a sexually transmitted disease from HPV. And I thought that was a good way to approach it. And then another thing, so one example that I have faced in my clinic is parents not wanting the vaccine just because they think that if they are protecting their children against a sexually transmitted disease, that their children are going to go out and start having sex. And that was definitely covered on this tip sheet, which I thought was good. And what the tip sheet says is things that you might discuss with the parents. For example, that there are several studies that are showing that teens actually don't begin to have sex. They don't feel like it encourages them to have sex sooner or at all because they got that vaccine, that it's just another vaccine in their list, in their arsenal. And so I think that it's important for us to kind of change our mindset into referring to it as preventing cancer rather than preventing a sexually transmitted infection. And that might help parents as well. And I think we also have some great public service kind of commercials that are going about saying, this could have prevented these cancers. And I think that that's a good highlight to have. So in summary, the cost burden of HPV-related disease is pretty substantial. And it is going down because we are decreasing the rates of HPV-associated cancers and diseases. However, we can be doing better with this vaccine. I believe that it's still only in the 30 to 40% that we're being vaccinated for against this virus, and we need to up that. Now it's gotten much better since when it came out, but I think we still have much room to improve. The second thing to note is that timing is really important, and as I showed on that youth resiliency survey, the incidence of cervical cancer has decreased, but it remains pretty high, and we need to make sure that the children are vaccinated prior to starting sexual activity. And we see that they're starting that activity as early as age 11 or 12, which is why we start the vaccine at that time period. And then also some socioeconomic status of minority affects their access to this. So we need to, from the previous slide, you could see that it was a prominent infection in the Hispanic or Latino population. Since we have such a large percentage of that population within New Mexico, it's important that they have access to this vaccine because it will make a difference down the road in decreasing costs and increasing their health and their quality of life. So at this point, I'd like to go over any questions, any insights that you may have had at your clinical practice in dealing with parents that don't want this vaccine, or how you may approach discussing this vaccine, or any other concerns. So HPV vaccine, give it a shot. I think it's a very worthwhile vaccination to be giving. Thank you. Have a nice day.